All right, next up is pacing. You see a patient, they have bradycardia, they have hypotension, it's wide complex, it's an agonal or it's a third degree. They're not peri-arrest, but boy, they're not looking good. You think pacing can work. Is it a slam dunk? Are you the only person who has ever had problems with pacing? And I know if you feel like you're the only one, you don't want to tell other people, and then other people think they're the only ones. Dr. Miller is going to tell you it's not just you. Dr. Miller.
Hey everyone, I'm Brian Miller, one of your Associate System Medical Directors. Welcome to this module, which I'm naming So You Think You Can Pace. This is not another review of the pacing basics today. Our goal is to fundamentally change how we think about pacing so we can make it safer, more deliberate, and more effective for the patients who truly need it. Here's what we want you to take away from this module today. You should understand why transcutaneous pacing is less reliable than many of us were taught. We want you to be able to identify false electrical capture by recognizing common misleading EKG patterns. We want you to recognize why manual pulse checks during pacing often lead us astray and how to confirm mechanical capture using the objective physiological data instead. Next, we want you to select the right patients for pacing, and we overall want to execute pacing more deliberately and safely after this module. To understand the challenges we face with pacing today, it helps to briefly look at where pacing came from. The first external pacer was used in 1952 by the Dr. Paul Zoll, whose name is still on the monitors we use every single day. Transcutaneous pacing entered emergency care in the 1960s and 1970s, with most of the supporting research published in the 1980s through the early 2000s. Those early studies were small, inconsistent, and even included Brady asystolic cardiac arrest, or what we would now know as PEA, with widely variable definitions of capture as well. Not surprisingly, pacing in cardiac arrest never showed the benefit and was finally removed actually shockingly late from the AHA guidelines in 2005. As a result, nearly all the evidence supporting transcutaneous pacing for symptomatic bradycardia comes from an older era, and modern practice is driven more by historical use, and we always did it that way, and guideline consensus than contemporary high-quality trials. The equipment used in these studies also was very different from what we use today. Older pacers delivered longer pulse widths, meaning longer pacing impulses, which made capture easier at lower currents, but caused significant artifact and certainly hurt the patient. Modern monitors use much shorter pulse widths now, improving patient comfort, but it also allows us to see and interpret the EKG far more clearly. That improved ECG visibility introduces a new problem though. Because pacing artifacts are smaller and cleaner, it becomes more easy to interpret the tracing and convince ourselves that electrical capture is present when myocardial depolarization is not actually occurring. In other words, the EKG can look organized and even convincing, even when true electrical capture is absent. This phenomenon is known as false electrical capture, when we believed electrical capture is present despite the absence of that true myocardial depolarization. I want to be honest with everyone. We have a problem with pacing, and this is not a single system issue limited to Fort Worth. Emerging data makes it clear that this is probably a widespread challenge across lots of EMS systems in the country. For years, we believed pacing was working because we did not have the tools or the insight or the data to clearly see when it was not. In many ways, ignorance is bliss. Now that we can see and analyze pacing more clearly, that assumption no longer holds, and it forces us to re-examine how we use and verify this therapy. Over the last year or two, several new studies have examined modern pre-hospital transcutaneous pacing using monitor file reviews and additional data sources. Together, they give us a much clearer picture of how pacing is actually performing in the real-world practice. The first study to review is the Kimbrell et al. Case series, and this was actually one of the first to directly challenge our assumptions about pacing with data. Researchers reviewed monitor files from 23 adults with unstable bradycardia who received transcutaneous pacing in 2 hospital-based 911 EMS agencies in Queens and New York City. 2 trained paramedics, blinded to the clinical context, reviewed only the ECG for evidence of true electrical capture. They used a modern definition of capture, a very wide QRS followed by a consistent, tall, broad T wave. When crews documented capture, but there was no electrical evidence of that on the ECG, those cases were classified as false capture. What they found was only 4 of the 23 patients had true electrical capture, meaning more than 80% did not have electrical capture. More concerning, in every case of false capture, all 19 of them, the crews documented mechanical capture based on palpable pulses. In patients with true electrical capture, though, systolic blood pressure increased by a median of 40 points. In patients with false capture, there was essentially no change. The median pacing current was also higher in the true capture group, about 95 milliamps compared to 70 milliamps. The takeaway from this study is pretty straightforward. Most capture documented in the field was false, and manual pulse checks were not a reliable indicator at all of pacing success. Next, we zoom out from a small case series to a big national EPCR and outcome data set using the ESO Data Collaborative from 2018 to 2021. The authors identified more than 13,000 patients who received transcutaneous pacing. Patients were grouped into those who arrested after pacing began, those who were paced and never arrested, and those who were paced after ROSC. Among patients who were not in cardiac arrest when pacing was started, nearly 8,000 patients, more than 1,600 progressed to cardiac arrest after pacing, about 20%, meaning roughly 1 in 5 non-arrest patients deteriorated shortly after pacing began. The median time from pacing initiation to CPR was just under 5 minutes. The authors also looked at predictors of pacing failure. They found that an oxygen saturation below 80%, as well as a respiratory distress or respiratory arrest primary impression by the crew, and a pre-pacing heart rate above 50 beats per minute were all associated with substantially higher odds of pacing failure, with hypoxia carrying the highest at a roughly 6-fold increased risk. Among all paced patients with available outcome data, nearly 2/3 died before hospital discharge. I don't want you to take away that this study is showing that pacing causes cardiac arrest, but because electrical and mechanical capture could not be assessed in this trial, it raises important questions about how often pacing is truly successful in real-world practice. It reinforces also the importance of patient selection, as pacing is unlikely to reverse deterioration driven by hypoxia, acidosis, or peri-arrest physiology. I now want to shift to present some data from the 2025 Resuscitation Science Symposium that was held in November. There are 2 interesting studies from this one. The first was similar to the Kimbrell case series. This study from Seattle Medic 1 reviewed 56 transcutaneous pacing cases over nearly 7 years. They analyzed the cardiac monitor files, as well as the audio recordings from the LifePak, as well as the EPCR documentation. Electrical capture occurred in about 32% of patients. However, even when capture occurred, it was rarely sustained. Complete electrical capture, defined as capture during more than 75% of pacing spikes, accounted for a median of just 14% of the total pacing time. Intermittent capture accounted for only less than 2% of all of that. The audio review added another important finding. Medics were heard reporting palpable pulses in 19 patients, but only 15% of those pulse checks coincided with true electrical capture on the EKG review. In other words, pulse checks were misleading roughly 85% of the time in this study. When electrical capture was present, again, systolic blood pressure improved, and also survival to hospital discharge was higher. This raises an important follow-up question though. Even when electrical capture occurs, how often is it actually sustained? And that brings us to our next study. This one was a multi-center retrospective cohort across 4 EMS agencies evaluating sustained electrical capture in patients receiving transcutaneous pacing. The authors reviewed 299 patients over a 7-year period who received more than 60 seconds of pacing. They looked at the cardiac monitor files and independently analyzed to determine whether there was true electrical capture and whether it was sustained. Sustained electrical capture was again defined as capture present in at least 90% of pacing spikes and maintained until pacing was either stopped or CPR was initiated. Only 29 of the 299 patients met that definition. Yep, that's just under 10%. In other words, more than 90% of PACE patients never achieved sustained electrical capture. The authors also evaluated predictors of sustained capture. Higher pacing current, again, improved the likelihood of sustained capture with every 10 milliamp increase associated with higher odds of success. Despite this, though, sustained electrical capture did not clearly reduce the risk of cardiac arrest after pacing. Patients who achieved sustained capture also had a higher adjusted mortality, likely reflecting greater illness severity and more aggressive intervention rather than the actual harm from the pacing itself. Taken together, these studies aren't saying that there isn't a role for pacing. However, what they do tell us is pacing is less reliable than many of us were taught and understand. True electrical capture is uncommon, and manual pulse checks frequently are going to mislead us into believing pacing is working when it is not. This should feel similar. False electrical capture during pacing is basically the parallel or the equivalent of unrecognized failed airways, where misleading clues lead us to believe we're helping the patient when actually the patient continues to deteriorate. Recognizing this problem should drive change in how we approach pacing. It means pacing only helps when it is used for the right patient, performed deliberately, and verified correctly. Knowing this, the question becomes, what do we need to do different now? 1. First, we need to be more deliberate about patient selection when pacing. Pacing is not a general rescue therapy for all crashing patients. It's a targeted treatment for specific physiology, and when we go outside of that, it's probably unlikely to help. Our protocol requires bradycardia with hypotension. That matters. No hypotension, no pacing. But even when both are present, we still need to pause and ask whether pacing is actually addressing the problem in front of us. One situation that deserves particular caution is the peri-arrest or that post-ROS patient who is bradying down quickly. If the patient's life status is questionable, meaning they're unresponsive, unreliable, absent SpO2 waveform, very low, single-digit end titles, no obtainable blood pressure, and you're unsure if they really have pulses, we have to consider whether that patient is bradycardic arrest already or PEA, and that is not a pacing problem then. Please err on the side of caution. If the arrest is possible, start CPR, treat the arrest. The cause of cardiac arrest is too great, and pacing often masks that re-arrest or that arrest altogether. Another common scenario is hypotension with only mild bradycardia, particularly if it's a sinus bradycardia. In these cases, think really carefully about alternative causes before pacing. Hypoxia, hypoventilation, acidosis, meds, and tox causes frequently drive both hypotension and mild bradycardia. Address the oxygenation and ventilation first, then reassess the heart rate. If the problem is not a primary conduction issue, pacing alone is probably not likely to help. Consider push-dose epinephrine and an epidrip, and those may be more appropriate than pacing. Hypothermia also deserves a specific mention. In cold patients, bradycardia is just a physiological response rather than a conduction failure. These patients do not need to be paced. They need to be rewarmed. The patients most likely to benefit from pacing are those with those true conduction diseases, high-grade AV blocks, complete heart blocks, accompanied by hypotension and those signs of poor perfusion. That is where pacing fits and where it has the greatest chance of success. Being more deliberate about patient selection reduces pacing attempts and lowers the risk of missing that cardiac arrest. Once we have selected the right patient, how we set up and start pacing is critical to the success. We begin with pad placement. Whenever possible, use the AP or the anterior-posterior pad placement approach. This is supported by physiological principles and is consistent with available clinical evidence. AP placement reduces the impedance of the chest, delivers more efficiently to the myocardium, and may be associated with higher rates of successful capture at a lower delivered energy. If you're using an anterior lateral placement, such as in a post-ROS patient, you can attempt pacing, but expect captures to be higher, and you may need to consider placing an anterior-posterior pad position if you're unsuccessful. As you all know, we're going to start pacing at 70 paces per minute with an initial output of 30 milliamps. And then we're going to crank that milliamperage up and assess for electrical capture. A common error that we see, though, is stopping too early and too low on that current. We see crews often stop in that 50 to 70 milliamp range believing they have capture. However, insufficient current is the most common reason pacing fails. Be highly skeptical of capture at those lower milliamps. Based on the data that we see, true electrical capture most often occurs at higher milliamps, frequently around that 90 to 120 range. Another recurring error is adjusting the pacing rate in an attempt to achieve capture. Changing the rate does not create capture. If capture is not present, the issue is current, not rate. Rate adjustments matter only after you get electrical and mechanical capture confirmed. If you do choose to pace a crashing peri-arrest or post-ROS patient, Don't creep up those milliamps slowly. Rapidly increase that current and don't hesitate to max out at 140 milliamps if capture is not present initially. Give your best shot first and quickly reassess and make a decision if pacing is going to work or not, adopt or abandon it. Pacing should function as a deliberate feedback loop. We adjust the milliamps, assess for electrical capture, reassess after the changes. Let's now pair up the monitor adjustment with how we assess true electrical capture. I really want to drill down on this area and how we assess the EKGs. False electrical capture is a major patient safety issue and the most common reason pacing fails. We see this regularly in our QA pacing cases, and it was consistent finding in our studies earlier that this is a problem. Let's start with what true electrical capture looks like, and then we're going to move to the EKG findings that signal false or absent capture. True electrical capture produces a wide QRS complex with a consistent and tall and broad T-wave following it. These morphologies should be repetitive and identical beat to beat. There should not be complexes that are physically impossible, meaning beats that are occurring to the refractory period of the preceding QRS. Let's cover first phantom QRS complexes. These are pacing artifacts that can masquerade as capture. They appear as arcing or angular complexes with a sharp, near vertical downstroke and a curved return to baseline. There is no discernible T-waves on these. As pacing current increases, these complexes often get larger and could falsely reassure us that capture has occurred. Remember, paced ventricular depolarization occurs outside the conduction system, so true capture is slow and produces a broad, slurred QRS, so these sharp, pointy, and narrow complexes are not indicative of true ventricular capture. Our second one is pacemaker dissociation. This occurs when pacing impulses are not actually linked with the intrinsic rhythm seen. The pacer spikes and the native rhythm march independently across, creating the appearance of two competing rhythms. You may see pacer spikes falling within P waves or even too close to the intrinsic QRS complexes. Importantly, the heart has an absolute refractory period. A QRS complex cannot physiologically occur within another QRS. So when you see that pattern, capture is not present. Our last one is pseudofusion. This occurs when a pacer spike happens to fall just before or just after an intrinsic QRS complex. It can briefly look like a pacer triggered the beat, especially when the QRS is wide and has that T wave. However, if you march the rhythm out, the relationship between the pacer spike and the QRS will not be consistent. These are chance interactions, not true capture, and are commonly mistaken for capture in real cases. Because of these pitfalls, printing a rhythm strip might be helpful during pacing, and sometimes you can make these patterns out easier and identify them on paper rather than looking at your monitor screen alone. All right, that was a lot of info really quick, so let's go over the 3 red flags for false electrical capture again. Phantom QRS complexes. These are the visible pacing artifacts that resemble QRS complexes but are not true depolarization. They have increasing QRS amplitude as we rise the milliamps, and that's a warning sign. Pacemaker dissociation. Pacer spikes are occurring independent of the intrinsic rhythm, the rhythms march separately, and the complexes violate the refractory period, indicating that this is not capture. Pseudofusion. This is the chance overlap between pacer spikes and intrinsic beats. There's an inconsistent spike to QRS relationship there, also indicating no capture. Notice how we have not talked about mechanical capture yet? That was intentional. We cannot have mechanical capture without true electrical capture. It is a simple concept, but one we often get backwards. We sometimes convince ourselves we have mechanical capture when if we look more closely, electrical capture was actually never present. This matters because relying on palpated pulses as our primary marker of capture is dangerous. In the studies we discussed earlier and in the OMD's extensive experience reviewing pacing cases, the majority of cases where electrical capture was falsely assumed involved crews palpating pulses and believing they had mechanical capture. In some of those studies, this occurred in upwards of 85 to 100% of false capture cases. The bottom line is that pulse checks alone are not reliable for confirming capture. So why is palpating a pulse so problematic? Even outside of pacing, pulse checks are imperfect. A recent systematic review and meta-analysis comparing manual pulse checks to point-of-care ultrasound and cardiac arrest found a false positive rate of about 9%. That means a pulse was incorrectly identified when none was present in roughly 1 out of 11 cases. During pacing, this problem is even further amplified. Electrical stimulation at 70 times per minute causes skeletal muscle contraction that we could easily mistake for a pseudo-pulse. In recognition of this, the AHA moved away from carotid pulse checks and recommends a femoral site when pulses are checked. In addition, our pacing patients usually still have an intrinsic pulse, unlike a cardiac arrest patient. This further increases the risk of false reassurance when capture is not present, because we may simply be feeling the patient's underlying bradycardic pulse rather than a true paced output. Because of these limitations, we need to rely on objective physiological markers rather than pulse checks alone. The SpO2 waveform is one of the best tools we have, although not all pacing patients will have that reliable waveform due to poor perfusion. When we do have one, pulsatility matters, and the SpO2 waveform should match the pacing rate. If the waveform continues at the pre-pacing rate or is inconsistent with the rate, we should truly question whether we have electrical and mechanical capture. End-tidal CO2 is another excellent marker for evaluating for effective pacing. With successful mechanical capture, end-tidal should improve as cardiac output increases. If end-tidal CO2 fails to rise, drops, or disappears entirely, we should be very concerned that capture is not present. This is especially critical in peri-arrest or post-ROS patients. Following end-tidal single-digit values or complete loss of end-tidal during pacing is most likely not an airway problem. It's a pacing problem and probably a signal that you have an impending arrest or that your patient has already arrested. Blood pressure trends are another objective marker, but they require context. During pacing, we should set the blood pressure cycling to every 2 minutes as we do for almost every critical patient that we have. If blood pressure is not improving, is failing, or repeatedly airing out, we should question capture. We also need to be cautious of isolated or unexpected high readings. In our QA reviews, we have seen cases where blood pressure appeared to improve despite the absence of electrical capture. That's probably due to the pain-induced sympathetic response rather than the true increase in cardiac output. Mental status can provide us some supporting information, but also we can't use that one alone. Patients may appear more alert, well, because you're shocking them at 70 times a minute, and that is discomfort from pacing, not because of effective perfusion has been restored. Without true electrical and mechanical capture, improved alertness does not reflect meaningful hemodynamic improvement, unfortunately. The takeaway is simple. We need to stop relying on pulse checks as our primary confirmation of capture during pacing. Instead, we need to use a combination of objective measures. Track end-tidal, evaluate the SpO2 waveform, and closely follow the blood pressure trends. Advanced tools such as Doppler pulse confirmation or ultrasound can be useful and maybe eventually be available to our CCPs, but those are going to be beyond our discussion today. Finally, I want to address a common misconception that once pacing is started, it can't be stopped. If you have any concern that capture is not present and that the patient's life status is unclear, we should turn off the pacer, reassess the rhythm, and ensure that the patient is not in cardiac arrest. I want to quickly acknowledge two individuals whose work informed this module. Josh Kimbrell, author of the paper on false electrical capture, and Tom Boothele, author of the EMS 12 lead blog. I learned a great deal from both of these guys while preparing for this talk, and I encourage you to go read Tom's posts on transcutaneous pacing to further develop your ability to recognize true and false capture. That wraps up our module on pacing. Thank you for your attention and your continued dedication to improving patient care in our system. Take care and be safe, everyone.
Great job, Dr. Miller, giving us a comprehensive background on pacing from Dr. Zoll to where we are right now. Here are the things that I took away from what Dr. Miller taught us. Number one, pacing is hard. It's hard for everyone. It doesn't work, and it doesn't work a lot. It's not just you. It's not just me. It's not just Fort Worth. It is not just EMS. It's happening everywhere. Transcutaneous pacing is hard. More than 80% of people who get pacing started doesn't work. We don't get good capture. What are the things that I picked up from Dr. Miller's review of the literature? Well, look for phantom QRSs. If you're seeing a sharp, narrow QRS complex that doesn't have T waves, you probably don't have capture. Look for pacemaker dissociation. I think about this as third-degree heart block, but with pacing. You see a pacer spike, you see QRS complexes, but they have nothing to do with each other, just like those wayward P waves in QRS complexes in third-degree heart block. And then pseudo-fusion. You have some capture, you have some non-captures. It is just inconsistent. It's got to be consistent, y'all. That's not what capture looks like. Well, what does true capture looks like? Well, it should have a wide QRS with broad, tall T waves. This should be consistent from beat to beat to beat. It can be hard to identify that on the monitor, so print a strip and take a look. That's what true capture looks like. Now, we talked about pulses, and Dr. Miller did a great job talking about how hard pulses are to detect, particularly in patients that you're pacing. Don't let your perception of pulses convince you you have electrical capture. Pulses lie. They're lying liars. They lie. Don't depend on them. If you see a significant blood pressure increase, and it should not be subtle here, goes up by 40, 50 millimeters of mercury. If you see your end tidal spike up, if you see consistency between the pleth on your SpO2 and your heart rate, those are all heart rate on the ECG. Those are all indications of good capture. Look for those. I like alliteration, so I'm going to say we need to pick our patients precisely. Sinus Brady very rarely requires pacing. If you don't have hypotension, no pacing for you. No hypotension, no pacing. Just like when we talk about darting the chest for a tension pneumothorax, if there's no hypotension, there's no tension, there's no dart. Don't pace a bradycardia just because it's slow. You need slow and hypotension. Now, if you have a patient who's hypotensive and they have a heart rate, narrow complex, let's say it's a sinus and it's in the 50s, man, you need to think 2 times and then another time and then another time. Are you absolutely positively sure that this heart rate is causing that hypotension? Because it's unlikely, and because pacing doesn't do anything for hypothermic bradycardia. It doesn't do anything for hypoxemic bradycardia. This is where we have to do the clinical part of clinical medicine. Use your decision making. Can the pacing possibly help fix the hypotension? If they're not bradycardic, clearly that ain't going to do it. And if they're just a little bradycardic, that's probably not the cause. You need to keep looking. Dr. Miller brought up peri-arrest patients. These are the ones that I think about that you get on scene, they have a systolic, say, under 50. It is really, really bad. They have an SpO2 under 50, which means it's just a crapshoot what the SpO2 really is. All we know is it's bad. Those patients need pressors. They need oxygen. They need warming. They need you to fix what's wrong with them. Pacing, you're almost never going to get capture, and it's probably not what's wrong with them. Go for the pressors. Go for the push dose. Go for the oxygen, the good ventilation. When in doubt, start CPR. Placement tips I got from Dr. Miller: go with AP placement first. Rapidly titrate those milliamps. Don't concern yourself if you find yourself at 140. That's okay. Titrate that milliamp up until you're sure you get capture. Remember the heart rate. Just leave that heart rate button alone. You can crank it up all you want. If you don't have capture, it's not going to increase your capture. Remember, rate does not improve capture. So that's what I took away from Dr. Miller's summary. Again, great job.